And my guide is Dr. Sir, and my course director is Dr. Sandeep Diwan sir. And I'm very happy to learn a lot of things in this forthcoming year. And this is my first presentation of this year.
But for you, Naveen, we have jumped from lumbosacral plexus to PNS directly.
Sorry, ma'am?
For you, we have jumped
Ah,
from lumbosacral plexus to PNS directly.
yeah, ma'am. Initially, yes, it
And I
was.
was I was very happy when sir told me ki Abhishek told me ki oh he's ready, he will present lumbosacral. I was like, wow, the first class is starting from lumbosacral.
Yeah, ma'am.
Avinash sir, I think we should go ahead.
Yes, it's a 704. At the 11 participants are there. We can start now.
Yeah. Students are here, so we can go ahead, sir.
Yeah, then it's fine. Students are there. We can start then.
Yes, sir. Naveen, you can go ahead.
Okay, ma'am, sure. So, good evening, everyone. So, today I'll be presenting about a peripheral nerve stimulator. So, yeah. So the main aim of any regional anesthesia technique is either to locate a nerve or a compartment which contains the nerve and deposit a local anesthetic either close to the nerve or inside the compartment in order to block the nerve conduction. So coming to history, so in 1909, Louis Lappick, he was the first who studied the electrical nerve stimulation. Followed by that, in 1912, von Perthes, he did the first PNS guided nerve block. And in 1955, Pearson demonstrated the electrical stimulation of the nerve by an insulated needle. And in 1962, Greenblatt and Denson, they have devised a portable transistorized nerve stimulator. Followed by which in 1969, Wright, he has demonstrated the block 8 monitor for nerve blocks, after which the PNS got famous. And Umre, he has also described about the PEG, which is the percutaneous electrode guidance, which is a non-invasive technique of finding the course of the nerve or mapping the nerve. So coming to basic electrophysiology, so any nerve, they always stay in the negative resting membrane potential. So the neurons have a negative resting membrane potential of minus 70 millivolts. So in order to stimulate the nerve, there should be a change in the ion permeability. So the stimulus should be strong enough to depolarize the membrane sufficiently and set off an action potential. So if the initiation of the stimulus is not enough up to the threshold, the stimulus will not happen or the action potential will not be set. So if the stimulus is not strong enough and applied for a longer time, or if the strong stimulus applied for a very short time, these two will not produce an action potential. So a current of sufficient amplitude applied for a sufficient time will depolarize a nerve, which gives either a motor or a sensory response because most of the nerves are mixed. Now, coming to the stimulation of the nerve, it can be either a cathodic or an anodic stimulation. But we are focusing on cathodic stimulation because that will only depolarize the nerve. The anodic stimulation will hyperpolarize the nerve, which we don't want that. So, coming to the current, so there is a term called Rio-base, which is the minimum current of indefinite duration required to depolarize a nerve. And chronaxy is the minimum duration required to stimulate a nerve if the current is twice the Rio-base. And the threshold current is the lowest current which produces a motor response, which is 0.2 or 0.3 to 0.5 milliamperes. So coming to chronaxy varies in different nerves depending on their sensitivity and the refractory periods. So A alpha, which is the motor fibers, which have a smaller chronaxy due to a shorter refractory period than a slow conducting sensory fibers. And also the chronaxy is inversely proportional to the nerve fiber size. So A alpha motor fibers is considerably bigger in diameter compared to the other sensory nerves. So it can be stimulated easily. So, stimulating a motor nerve fiber requires a shorter pulse than a sensory fiber. The A-alpha motor fibers, they have a diameter of 12 to 20 and it's myelinated. It requires a chronaxy of 0.05 to 0.1 millisecond. And A delta, which is a sensory fiber, which is again myelinated, it requires a chronaxy of 0.15 millisecond. And C sensory fibers, which is unmyelinated, they require a high chronaxy, which is 0.4 millisecond. And this is the strength duration curve. So as we can see, this is the motor, and this is the A delta, which is the sensory nerve fibers. So the motor nerve fiber will require a shorter chronaxy when compared to the sensory fibers. So coming to needle to nerve distance, so we'll talk about Coulomb's law, which is the inverse square law, which states that the current which is required to stimulate the nerve is inversely proportional to the square of the distance from the nerve. So as the needle approaches the nerve, the less current is required to stimulate it, and vice versa. So if the current is not reduced, when the needle is approaching the nerve, if the current is not reduced, the motor response amplitude will increase. So the current is decreased until a final amplitude of 0.3 to 0.5 milliamperes. But in patients who are elderly, diabetic, and neurological diseases, they may require a higher current due to slower nerve velocities and lower motor amplitudes. Now coming to the properties of PNS, so there are basically 5 properties. One is the shorter pulse width. So a pulse width is the time for which the current is applied. So as you can see in the diagram, this is the pulse width. This is the time for which the current is being applied. So it's either called as chronaxy. So motor fibers have a smaller chronaxy. So shorter pulse width stimulate the motor fibers, but not the sensory fibers. So the patient will have a motor response in spite of paresthesia. So that is what we want. This is superior to a longer and stimulating needle to nerve distance. Square wave current is, so a current should have an abrupt rise and an abrupt fall. If it has a slow rising current, it will lead to accommodation resulting in difficulty in nerve stimulation. And coming to the nerve stimulation, it should be cathodical stimulation, which will depolarize the nerve, and the anodal stimulation will hyperpolarize the nerve. So if the nerves get hyperpolarized, a larger current is required to depolarize the nerve. So coming to the frequency, the stimulation frequency can be either 1 hertz or 2 hertz or sensi. So the hertz is the number of cycles per second. So 2 hertz can help in faster manipulation of the needle. So this sensi mode is a sequential electrical nerve stimulation technique which uses an additional stimulus with a longer pulse duration after 2 regular impulses at 0.1 milliseconds. So this becomes like a 3 hertz. And this PNS must have a constant current generator. So a PNS should deliver the same current between the anode to the cathode despite the change in impedance. So the impedance is the resistance or opposition to the electrical flow offered by the tissues. And the unit of resistance is calculated as ohm. Coming to needles, so there are non-insulating needles and insulating needles. So in non-insulating needles, both the tip and the shaft were conductive, which causes current dispersion and local muscle stimulation by the shaft of the needle. And insulated needles, they are Teflon coated, which has better precision because only the tip is conductive, and hence the current is not dispersed. And the needle tip either can be a long bevel or a short bevel. The long bevel is 15 degree and a short bevel is 30 degree. A long bevel needle lead to sharp cuts on the nerve, but more frequent nerve injury can happen. But a shorter bevel needle have leads to blunt nerve damages, and it causes more severe nerve injury, offer more resistance, but they give a better tactile sensation or feel. Coming to the size of the needles, so for a single shot injection, we can either use a 20 gauge 100 millimeter or a 22 gauge 50 millimeter needle. For a continuous catheter insertion, we can either use a 18 gauge Doherty tip needle with a 20 gauge catheter, which can be inserted in it. So as you can see, this is a non-insulated needle. So the tip and the shaft, they are all conductive. So they cause current dispersion to the entire needle, and it's got local stimulation of the muscles. So the desired motor response is not accurate. In insulated needles, the complete shaft is coated with Teflon. Only the tip is conductive. So you get a better motor response, which is precise. So as you can see here, the complete shaft and the tip of the needle is conductive. So it may require a higher current for us to identify or locate the nerve. which can cause that desired motor response. And the needles which are coated with Teflon, so they have a very precise, or only the tip is conductive. So it may require a very low stimulation current to get the desired motor response. And coming to the length of the needles, so the appropriate needle length for nerve block is described, but it differs from patient to patient. So normally for an interscalene, they are saying it is 25 millimeter, and 50 millimeter needles are used for cervical plexus, supraclavicular, axillary, femoral, posterior popliteal, and 100 needles are used for infraclavicular, lateral popliteal, paravertebral, lumbar plexus, and posterior sciatic. And a long 150 needle can be used for anterior sciatic. And coming to the components of the nerve stimulator, so this is the main component. So it has a microcontroller, which is the brain of the PNS, which processes the variables like current, pulse width, and the frequency. And it has a constant current generator, which generates the same current despite change in impedance. So as you can see in the image, this 1 kilo ohm, this is the resistance which is offered by the tissues when the needle is passing through different tissue layers. And this will vary. This might vary, but the current which is being offered by the PNS machine will not vary. So an oscillator is which generates the desired frequency, and the clock reference which synchronizes the current with the frequency. And it has an LCD display for the current amplitude, frequency, and the pulse width, and the controls for changing the parameters. So as you can see the image, the 0.3 milliamperes is the set current. And this 0.1 millisecond is the pulse width or the chronaxy which has been set. And 2 hertz is the frequency, and 1 kilo ohm is the resistance which is offered by the tissues to the needle. So during a nerve stimulation, so we need a cathode which is a negative to the needle or the black to the needle, which is universal code, and anode which is positive to the patient or the red. And the current must be a square wave impulse. The pulse width should be 0.1 millisecond. The frequency can be set according to 1 hertz, 2 hertz, or sensi. The current range will start from 0 to 5 milliamperes. So we can start at an initial current of 1 to 2 milliamperes depending on the patient and the site of nerve block we are offering, to a final current of 0.3 to 0.5 milliamperes. And beyond this, less than 0.3, it becomes intraneural. So the anode must be placed at least 20 centimeter away from the needle site to reduce direct muscle stimulation. But some studies, they have found it to be unnecessary, can be placed closer also. So above 0.5 milliamperes, the needle may be further away from the nerve and the block can be unsuccessful. And below 0.3 milliamperes, the injection can be intraneural. So it is always best to keep the final current between 0.3 to 0.5, or even 0.4 is ideal final current. And confirmation test, so the disappearance of the motor response, which is induced by the low current 0.5 milliamperes following a local anesthetic injection or a normal saline injection. 1 to 2 ml of local anesthetic or a normal saline can be injected. So these are conducting solutions. So this will cause disappearance of the motor response. So this confirms the proximity of the needle to the nerve. So this is either due to the physical displacement of the nerve from the needle or due to dissipation of the current density near the nerve. And there is something called a SUI test, which is you instead of local anesthetic or normal saline, you use 5% dextrose, which is a non-conducting solution. This will cause exaggeration of the motor response, which again confirms the needle to the nerve proximity. And this is a block which was performed by Dr. Sandeep Diwan sir, and this is a PNS guided lumbar plexus block. So as we can see, we are at a current of 1.2 milliamperes, and we can see the quadriceps contraction. So as the current is reduced to, so now the current is at 1 milliamperes, and we can see the quadriceps contraction. Yes, as we can see the quadriceps contraction at 1. And as we are reducing the current to 0.9, 0.8, gradually reducing it, 0.6, still the contraction is present. 0.46, now the contraction is absent. So this is an ideal place to deposit the local anesthetic. And this technique was performed under landmark guided only PNS. And this is a dual guided, so which is an ultrasound and a PNS guided. So we are doing a popliteal sciatic, and again the block is being performed by Dr. Sandeep Diwan sir. And sorry. Yeah. So now the current is set at 1 milliamperes, and dual guidance sir is entering close to the nerve. And we are expecting the desired motor response, which is inversion of the foot. So we are trying to increase the current to see if the desired motor response is obtained. Still, we are not getting that response, but yeah, so now we are able to get the motor response at 1.5 milliamperes. And as we reduce the current to 0.9, now the motor response is still present. To 0.48, it's still present. 0.4, 0.3. Yeah, until 0.3, the motor response is decreased. So sir is withdrawing the needle a little bit outside, and then the drug is being injected. So there was a study which was performed by Urme and Staten in 2002. So he has stated that a sensory response, which is paresthesia, presumably due to the nerve contact, was not associated with motor response in 70% of the patients. So what he's trying to say is there was a lack of motor response despite the current being 1 milliamperes, which exceeded the minimum current required to stimulate a nerve. And this result showed that the lack of motor response does not rule out the possibility of a sensory nerve contact by the injection needle, because the pulse width we have set, it's 0.1 millisecond, which is going to stimulate only the motor fibers, not the sensory. So we have to be careful of this. So, and coming to the continuous catheter technique, so we have two types of catheter, which is a non-stimulating catheter and a stimulating catheter. So there are two variables now. There is something called primary block and a secondary block. Primary block refers to the block following the initial drug injection, and secondary block is following the continuous infusion of the drug. So in non-stimulating catheters, the chances of secondary block failures are high. But in stimulating catheters, the catheter can be stimulated at intervals to find out whether the tip of the catheter is at the correct desired location and the desired motor response is obtained and the infusion can be restarted. So in order to avoid dislodgement or displacement of the catheter, tunneling can be done to avoid this, and it can maintain the catheter for a longer time. And this is a continuous catheter technique which was performed by Dr. Sandeep Diwan sir in our hospital, the interscaling stimulating catheter. So initially, as you can see, this needle is a stimulating needle, and this needle is being connected to the PNS, and this is the negative to the needle, which is the cathode. So this needle is a stimulating needle. This needle is going to stimulate the interscalene, which is C5, C6, and the desired motor response is obtained. And through this, the stimulating catheter is being inserted, and the PNS is changed from the needle to the catheter to find where the tip of the catheter is being placed. So let me play this video. As you can see the deltoid twitch, which is happening at 1 milliamperes. So, and after placement of the catheter, we can again stimulate the catheter and see whether the tip of the catheter is in the desired location and the motor response can be elicited. And we have two ports here. So one is for the drug and one is to connect the PNS and see the muscle stimulation. Yeah. So the optimal range of PNS is 0 to 5 milliamperes. This is used for the peripheral nerve blocks, and 0 to 10 milliamperes is used for epidural stimulation, and 0 to 80 milliamperes is used for neuromuscular monitoring. So there is a percutaneous nerve stimulation, which is a non-invasive technique which requires higher current than invasive stimulation. So where the tip is placed over the skin, so this helps to map the nerve in patients who are obese. And in order to avoid intraneural injection, an inline pressure monitoring device can be used, which measures at what pressure we are injecting. So if the pressure is more than 20 psi, then which means we are intraneural. And if the pressure is between 5 to 20, which is perineural, which is safer side to inject the drug. So coming to the last slide. So while using a PNS for a peripheral nerve block, so in our institute, we start with a desired initial current of 1 to 2 milliamperes with a pulse duration of 0.1 millisecond at a frequency of 1 or 2 hertz. So the current is gradually reduced as the desired motor response has been obtained, and the needle advances slowly to a final threshold current of 0.3 to 0.5 milliamperes at 0.1 millisecond. Now aspirate and give the test dose of 1 to 2 ml of local anesthetic, which will abolish the muscle twitch. Now we can increase the current to initial level and see if we are using only PNS technique, because this is again due to the dissipation of current and the displacement of the nerve from the needle. If there is no stimulatory response, we can inject the remaining drug. If there is a failure of the twitch to disappear on injection, or there is a pain on injection, or high pressure injection, that will suggest an intraneural placement of the needle tip, and this will warrant some withdrawal of the needle, and we can again proceed with the procedure. Thank you so much.
Thank you, Naveen. It
Thank
was
you,
a
ma'am.
very well-balanced presentation, especially PNS and all are very basic topics which we tend to ignore. So I would request the faculty to go ahead with question answer session, please. And this question answer session is open for all the fellows. Kindly participate.
Hello, Dr. Naveen.
Yes, sir. Good evening, sir.
Can you mention the problems with the PNS guided block only?
Yes, sir. So PNS guided block, there can be an vascular puncture can happen in the PNS guided block, sir.
Okay, why?
Sir, because it's a landmark guided technique. We are inserting PNS, so we are not knowing through what structures we are piercing through, so we can cause vascular damage.
Yes. So, do you recommend ultrasonography guided blocks?
Yes, sir.
Dual guided.
Dual guided, sir. So ultrasound along with PNS, we can go ahead, sir. So that will give a precise block, sir.
Naveen, do you use PNS in each and every block or anything specific?
Ma'am, in our institute, most of the patients we use PNS, ma'am, for axillary, for infraclavicular. We use PNS guided blocks, ma'am. So, and as I have shown you in lumbar plexus also we have done, and in popliteal sciatic also we have used.
Okay.
Any questions? Dr. Pooja?
Yes, sir. Naveen, can you tell us that how is the conduction in the nerves? Accordingly, we require the PNS response. So there is a different setting for sensory, like sensory require higher current than the motor nerve. So why is
Yes.
it so about the conduction of the nerves, conduction through the nerve?
Oh, why sensory requires? Sorry, I'm not getting you.
For sensory stimulation, we require a longer pulse duration. For
Yes.
motor, so the settings of the PNS is different for sensory and motor.
Yeah.
That is why we are getting motor responses, not the sensory one.
Okay.
So
Yes.
it does depend upon some factors of the sensory fibers and the motor fibers. So can you tell?
Is it because of the refractory period which is different for motor and sensory fibers? The motor
Actually,
fibers.
the structures of the fibers are different. There is a saltatory conductions in the myelinated fibers, and there is a continuous conduction in the unmyelinated C
Myelinated C
fibers.
fibers.
So
Okay.
motor fibers having a saltatory conduction, and the pain fibers, C fibers having a continuous conduction. So
Okay.
this structure, the diameter, the myelination, the conduction, all these factors are responsible. That is why we are getting motor response, not
Right.
the sensory response
Okay.
at the same setting.
Okay. Got it. Okay.
Hello, Dr. Naveen.
Hello, ma'am. Good evening.
Yeah, good evening. Is there any role of PNS in adductor canal block?
Uh, no, ma'am. I have not seen PNS used in adductor canal block, ma'am, because adductor canal block is more of a motor sparing block.
But if you need to block nerve to vastus medialis,
Yes, ma'am. Yeah, we can use PNS. Yes.
okay, because they are in different sheets, but at times when you are going towards saphenous, you might touch some fibers of vastus medialis as well.
Okay, ma'am. Okay.
Okay,
Yes,
so
ma'am.
it is good if you combine the dual modality for that same block.
Sure, ma'am. Definitely.
Avoid injury to vastus medialis.
Okay, ma'am.
Any other questions, doubts?
Ma'am, I would like to answer one of the question which Dr. Avinash sir has asked regarding the disadvantage of PNS. So, one more point I want to add on is while injecting the drug, we may not be sure whether the nerve is getting displaced or the knee needle being pushed away from the nerve. So the block can be unsuccessful also because it is only PNS guided.
What is the third component or safety component in giving any block? Just describe a part of it.
Safety component.
Are you talking about intraneural placement with the PNS?
Talking about the pressure.
Yes.
That we can use an
Okay.
inline pressure monitoring device, ma'am.
Right, right. Any other method when you don't have that pressure monitor?
So
Simple hands-on technique.
yes, ma'am. So we can feel for the resistance, which if we are injecting in the interfacial plane, we get less resistance, and if we are intraneural, we get high resistance on injection. But like that's a tactile sensation, like tactile feel, what we get, ma'am.
That tactile sensation actually develops with practice.
Okay.
So I have seen some people who prefer to have a technician to push the drug, and I never prefer that. Once I
Okay.
am done with the needling, I myself check the pressure because it's a tactile sensation which develops over time.
Okay.
And if somebody else is pushing the drug, you don't know how much pressure he or she is applying. Sometimes I've seen the technician putting full force. Instead
Right.
of thumb, he starts using the palm to push the drug.
Yes.
So tactile sensation is something which develops with practice, and it is something which can be done without having any equipments. So try to learn your blocks with injecting the drug and holding the probe in one hand and injecting the drug at the same time. It's
Okay,
need
ma'am.
practice, but
Okay.
we all are not that lucky to get every equipment at every place where we work. So develop that tactile sensation too in future so that it helps you to assess where the needle exactly is.
Yes, ma'am. Definitely.
Good evening,
Hello,
ma'am.
Dr. Naveen.
Hello, ma'am. Good evening.
Ma'am, Sangamitra, ma'am, I have one query regarding Sensi mode. Like, what is exactly the use of Sensi mode and where we are using it? Like, what is the novelty of that mode and where it is specifically indicated in PNS guided blocks?
Naveen, can you go ahead with Sensi? You have just described it.
Yes, ma'am. So, Sensi, can I just do the screen sharing once again?
Yeah, sure.
I'll go back to the slide. Yeah. So basically, ma'am, so we either use 1 hertz or 2 hertz. The Sensi is a 3 hertz, which uses 3 stimulus. So 2 stimulus is of a very shorter pulse width, shorter duration, and one of a longer pulse duration. So this leads us to easier and a faster manipulation of the needle to the nerve. We get a desired motor response even faster when we keep it in Sensi mode.
But is it specifically indicated in some cases? Like I have a query. I want to really ask that
I am
whether it is
not
indicated
sure.
somewhere.
Avinash sir, will you please continue? I just have a patient. I'll just come and join back in 5 minutes.
Okay. Dr. Naveen,
Yes, sir.
which syringe you prefer to inject the medicine? Means 2 ml, not 2 ml, 5 ml, 10 ml, or 20 ml?
So I would prefer a 10 ml or a 20 ml syringe, sir.
Okay. Now, second question, 10 or 20?
20 ml, sir.
Why?
You can, sir, I'm not sure, but I think with 20 ml syringe, we can feel the resistance even better.
Yeah, actually, a 20 ml syringe creates less pressure at its tip
Mhm.
compared to the smaller syringes.
Okay, sir. Okay, sir.
20 ml is recommended.
Okay, sir.
Yeah. You can see practically also if you are using
Yes, sir.
5 ml syringe or 10 ml, drug is injected very fast.
Yes, sir.
Yeah. Any other questions?
Hello.
Yeah.
Yeah, Dr. Naveen.
Yes, ma'am.
So suppose if you're doing the lower limb block and you
Okay.
put one electrode on one leg and the other electrode the technician has put on the other leg, will you get the response?
Yes, ma'am. I think we'll get the response.
Why? You will get the response, yes. Why?
It is,
You will get the same response.
yes, ma'am. Yeah.
But why? What is the mechanics behind it? Basically, you have to complete the circuit.
Yes, ma'am.
Yes.
Okay.
Ma'am, mathematically, the return electrode is it can be at infinite distance away from the needle according to the law. So
Correct.
we can get the response if
Yes.
the surface electrode is on the opposite limb. Just for the upper limb, we can't put it on the other side because it will pass through the heart.
Yes. So lower limb ke liye it is okay. You will get the
Yes, ma'am.
response because it will get completed. Correct.
Okay.
Yes, ma'am. Yes.
Yeah, but practically it may not be possible to give block in one limb and put electrode on opposite limb, because if you see the PNS machine and the wire, the two wires are stick together. If you want to put ECG electrode on other limb, you have to separate that wire. If you
Yes.
see, and that's practically not possible.
Yes,
And
sir.
there's no
Yes.
need also to keep put electrode so far away.
Yes, sir.
Hmm. And what the PNS generates is a DC current, not the
Yes,
AC
sir.
current. It's a DC
Yes,
current.
sir. Yes, sir.
Okay, Dr. Sangamitra is supposed to start that question quiz session, but I think she's not online yet.
Dr. Naveen,
Yes, ma'am.
now tell the lowest when you get, twitches to reduce the current, right?
Yes, ma'am.
So how or around basically in the nerve and I have to withdraw my needle.
So when you get a motor response at 0.2 milliamperes, which means that we are intraneural now. So that time we have to withdraw the needle and the final current should be around zero point 0.3 or zero point 0.4 milliamperes. So at that point, so we can be, safer side. We are not intraneural and we can inject the drug.
Yes, yes, good.
Is my screen visible?
Yes, yes.
Are there any questions, sir? Avinash, sir?
One question. Naveen, will you use 5% dextrose or distilled water?
Sir, I will use a distilled water or local anesthetic, sir.
Any problem with distilled water?
Yes.
Nobody.
Yes,
It
sir.
is not recommended. Why it is not recommended?
Sir, it is a distilled water or the local anesthetic solutions. These are the conducting ones. So if we, so the dextrose, I'll use dextrose as it is a non-conducting solution. So it will not hamper the peripheral nerve stimulation.
And another thing is, distilled water doesn't contain any electrolyte, but distilled water is irritant to the nerves, so it is not recommended.
Yes, sir.
Okay.
Yeah. Yeah, Dr. Sangamitra, you can proceed.
Yeah, this Kahoot quiz can be seen by all.
Yes, yes.
All the fellows are requested to scan and join the game, please. Very simple
Yes,
questions I
ma'am.
have kept. This is for the first time, so we are just on a trial basis. Meanwhile, Avinash sir, thank you for helping. I just had a plasty and extubation together.
It's okay.
Some more fellows, please. At least 5. Oh wow, fellow came. We went for a focus workshop and the names were like Shinchan and Pushpa, and so these are far better than that. One more, please. Shall we start?
Yes, ma'am.
Fellow is leading right now.
या या इकडे इकडेच आहे. काय संपत आलंय. मी पण संपवणार लगेच. सगळ्यांनी मला पीडीएम केलंय.
So now, can you please tell me who is fellow, is doc, and who is S?
Ma'am, fellow is me, Dr. Pooja
Okay.
from Sanchiti Hospital.
Now I have to believe you, right?
Thank you, ma'am.
Thank you, Pooja. Congratulations.
Congratulations, Pooja.
Ma'am. Thank you, sir. Thank you, sir.
Good.
Who is doc?
Doc is Mitali, ma'am, from Ruby Hall Clinic, Pune. Fellow from Ruby Hall Clinic.
Good job, Mitali. And S is?
Dr. Shefali from CAS Mumbai.
Great, great. So you got a very good teacher who has restricted himself and allowed you all to answer the questions perfectly. Congratulations, Naveen.
Thank you, ma'am.
It was really a very nice presentation, Naveen, on the
Thank
basic
you so much,
topics.
ma'am. Thank you.
Yeah. So Avinash sir, anything on your side? Otherwise, I think we have finished the topic. So Naveen, can we go ahead and get our class over today?
Yes, ma'am.
Yeah, they are out of questions for you, Naveen.
Okay, ma'am.